In this video, I'll be discussing first-line therapy for HER2 negative Claudin 18.2 positive gastroesophageal adenocarcinoma. And as we go through this, you will see that I will specifically be pointing this out for PDL1 negative tumors. So we've been talking in the first-line setting of the metastatic or palliative setting where the cancer is spread outside of the regional site of the origin of the cancer in the gastric or esophageal location, or if it's locally advanced or unresectable for whatever reason. And we've been showing this mind map on how we think about going through treatment after being diagnosed with stage 4 unresectable gastroesophageal adenocarcinoma through the different lines of therapy. And we've been focusing on first-line therapy. We've talked about the standard chemotherapy backbone of FOLFOX 2-drug chemotherapy regimen, or the alternative CapeOx with the oral version of the 5-FU capecitabine. We talked about triplet chemotherapy regimens like FLOT or FOLFIRINOX in certain select cases. And we've talked now about HER2 positive disease, and we've talked about PDL1 positive disease. And now we're going to be focusing on Claudin positive tumors. So going back to the TCGA, the Cancer Genome Atlas, which was a large effort looking at hundreds of samples, trying to molecularly profile them with genetics and protein expression and clustering them into like tumors. And for adenocarcinoma, we had 4 major categories: chromosomal unstable, Epstein-Barr virus positive, microsatellite unstable, and genomically stable. And when we're talking about now Claudin positive tumors, remember, we can talk about the DNA or we can talk about the protein. When we talk about the DNA, actually, one of these categories, genomically stable, has a genetic DNA alteration with Claudin 18 called a fusion with another gene. And the function of this is not really well characterized, but it happens in these genomically stable signet ring diffuse type cancers. And it occurs in all gastroesophageal adenocarcinoma in less than 1% of the tumors, but it does occur and it's clusters here. So it's a little bit more common when you speak about just genomically stable. However, as you'll see, what we're really interested in going forward, because that's what the studies assessed, was overexpression of the protein, even if the gene itself is normal in its sequence. And all 4 categories can have Claudin overexpression of the protein. And that incidence, as you'll see as we go through this, is around 25 to 35% of all the tumors screened will have overexpression by the criteria that we're going to talk about. And so, again, it tends to cluster here with overexpression, but there's no dramatic difference in incidence across these different subgroups. And of course, this is important when we talk about gene alterations or protein overexpression, because then we can match targeted therapies. And we've been discussing this over the many videos where all these different genetic alterations have potential matched targeted therapies, and in green, already approved matched targeted therapies in at least one line of therapy. And again, for this presentation, we'll be talking about Claudin 18.2, and I just mentioned that fusion which occurs in relatively rare subset of the patients, but it does occur there. And anti-claudin antibody Zolbetuximab, which is the focus of this presentation, is an option here. Again, this was not tested in the studies that we're going to be talking about as a criteria to be eligible for the studies, but generally speaking, these patients that have a fusion of this gene will likely have overexpression of the protein. Now, again, this is rare, and it tends to be higher in incidence in the diffuse type and signet ring peritoneal only disease. This is a chart that's only regarding the genetic alterations, as we've been talking about. But when we superimpose or overlay the protein overexpression, and specific to this presentation today is Claudin overexpression, which is around, again, 25 to 35% of all the tumors. And we have to, again, point out that each of these are not necessarily mutually exclusive. And so we're going to be pointing out, what if a tumor has both Claudin overexpression and PDL1 expression, or any of these other important biomarkers, or any of these other genetic events? What are we going to do, and how do we think about that? So we've talked about what is Claudin in previous videos, namely the targeted therapy video where we introduced zolbetuximab as a targeted therapy to Claudin. And so what is Claudin? Claudin is a protein that's expressed on the cell surface that keeps cells together. So if this is one cell and this is another cell, this is a tight junction complex, and there are a lot of different proteins that help to hold cells together. We've talked about ecadherin and the CDH1 group of tumors that lose this and therefore have loose diffuse cells. But here we're going to be talking about Claudin. And Claudin, as we will learn, is expressed in stomach cells and can be highly expressed in a subset of gastroesophageal adenocarcinomas in about 25 to 35%. And again, remember, there's this rare, relatively, fusion of this Claudin gene, and it tends to cluster in this diffuse type signet ring tumor set. And its function is not really clear in terms of how it contributes to the cancer, but it's there and present. And so zolbetuximab is an antibody that binds to the outside surface of the Claudin 18.2 on the outside of the membrane of the cell. And we talked about it, and I'll show you on other slides, that the main mechanism of action that we know of is that it works through antibody-dependent cell-mediated cytotoxicity, where it drags in natural killer cells and other immune cells into the vicinity of the tumor and helps with cell death. So that is antibody-dependent cell-mediated cytotoxicity, or ADCC. That's shown here in more detail. Remember, we've shown this slide before, that monoclonal antibodies, therapies, bind to a specific protein, and in this case, we're talking about zolbetuximab on the outside of cancer cells. And in many therapeutic monoclonal antibodies, like, for example, we've focused on trastuzumab and we talked about margetuximab in the HER2 positive lecture, that they can block the receptor activation and cause it to become internalized and degrade. In the setting of zolbetuximab with Claudin 18.2, again, the function of the Claudin is a little bit different than an oncogene and protein like HER2. And the main mechanism of action, again, that we're aware of is through this immune response, ADCC, where it's attracting natural killer cells through the back end of the antibody, that Fc domain, and dragging them into the vicinity of the tumor and having the natural killer cells then destroy the tumor. So that's shown here, where we focused on all the ways that natural killer cells can be enhanced with therapies. And we talked about this in the immunotherapy series, where one of the main ones was with antibody-dependent cell-mediated cytotoxicity, again showing that any antibody that's going to any antigen epitope on the cancer cell, in our case, we're talking in this lecture about Claudin 18.2, and it drags in natural killer cells through the receptor interaction, the CD16 receptor on natural killer cells that binds to the Fc domain of the antibody. And we've talked about many antibodies that can do this. And again, zolbetuximab is one of them, which it's one of its main mechanisms of action. So talking about zolbetuximab as an anti-claudin antibody, putting it into the context of what chemotherapy backbone is expected to do. We talked about the benefits of chemotherapy, how best supportive care medians, plotted on here, were on the order of 3-ish months historically. And with various chemotherapy regimens preferred these days as FOLFOX, the median overall survival approaches about a year. And this is summarized here in terms of what one might expect from clinical outcomes with just chemotherapy alone in the stage 4 setting, with a response rate at about 40 to 50%, disease control rate around 70 to 90%, depending on which study you're referencing. Median progression-free survival, the time that the cancer is controlled for before you have to switch, before it loses control, is around 6 to 7 months. And the median overall survival is around 8 to 12 months, usually on the higher end of that now that we have other therapies in second line and later line in tandem, even just standard chemotherapies. However, we've been talking about what if we have a targeted therapy, especially when there's a matched biomarker, and we've already focused on HER2 positive disease. Then we've talked about anti-PD-1 therapy, and specifically with PDL1 positive tumors. Now we're going to be showing what anti-claudin 18.2 therapy can achieve in the setting of claudin overexpressed or claudin positive tumors. In terms of tissue biopsy processing and biomarker testing, we've talked about where we get the samples, how the pathologist processes these samples, but most importantly and relevant to precision medicine and targeted therapies, we talked about other routine biomarker testing that's done with immunohistochemistry. Again, this is IHC, that is looking at protein expression. And again, relevant to this talk is Claudin 18.2. And then again, we can also obtain DNA and do next generation DNA sequencing. And this is where you might pick up Claudin fusions, that relatively rare genetic event. So again, these are two different things. And we're really going to be focusing mostly on the overexpression because that is what was looked at in the studies. And it's also far more common, as we've been talking about, 25 to 35% incidence, whereas the fusion is much less common. In terms of that immunohistochemistry assay, there is a specific diagnostic antibody assay that was co-developed as something called a companion diagnostic with the therapeutic antibody Zolbetuximab. And so this assay is sort of coupled with the therapy and tested as the test that they're going to be used to identify patients' tumors that have claudin overexpression. And remember, this is a predictive biomarker. If you have overexpression of Claudin 18.2, then it predicts benefit from anti-Claudin 18.2 therapy. And so we're going to be going through the evidence that supports that statement. And then again, in addition to that protein expression through immunohistochemistry, we talked about genetic testing with next generation sequencing that can test for 4 main types of genetic alterations: single base pair substitution, copy number changes, amplifications, or large deletions, or small insertions and small deletions of DNA, and rearrangements or fusions. And this is where we're talking about fusions, where different parts of the DNA are connected to each other abnormally. And there is a rare Claudin 18.2 gene fusion that clusters into genomically stable diffuse type signet ring tumors. Remember that next generation sequencing can be done at a number of commercial panels that are out there. That was listed on the previous slide, also academic centers. And this is one where we have to be careful in terms of looking for Claudin 18.2 gene fusion, because not all next generation panels have Claudin on the list. And so if you look through this Foundation 1 list, Claudin 18.2 is not there. And so if your tumor was tested with Foundation 1 testing, then you should know that it hasn't been tested for Claudin 18.2 gene fusion. Other panels out there, like say the Tempus XT panel, which does have the assay looking for the gene fusion. We didn't talk a lot about RNA sequencing, but some companies like Tempus does coupled DNA and RNA sequencing. And it turns out that RNA sequencing has a higher sensitivity of identifying gene fusions of any kind of gene fusion. This is the list of gene fusions on the Foundation 1 panel. You can see that Claudin is not listed here. And whereas because Tempus XT does both DNA testing and RNA testing, and specifically looking at Claudin 18.2, it is a test that's more geared towards getting and sensitive to identify Claudin 18.2 gene fusion. So what is the evidence then for using anti-claudin 18.2 treatment in first-line gastroesophageal adenocarcinoma? We're going to talk about the one therapy that has been assessed at large scale, and that is zolbetuximab. In the video that was the principles of clinical trials, I showed you this zolbetuximab storyline of the first study looking at this agent in preclinical models, in vitro and in animal models, and it was some time ago. And then we looked at the randomized phase 2 study, which we've known for some time was showing some benefit in claudin high tumors. And then there was a little bit of a delay in the development as the drug transitioned hands to a different company. And then what we're going to focus on mostly now is these two large phase 3 studies, SPOTLIGHT and GLOW, that recently reported earlier this year and will likely lead to an approval that is impending, hopefully, in the near future. So this was the first study, the randomized phase 2 study called the FAST study, that showed promise of this agent. And this study selected for patients that had Claudin 18.2 expression that was present in at least 40% of the cells in the sample being evaluated and had an expression intensity of at least 2+ on a scale from 0 to 3. So it had to have at least moderate expression intensity, brightness, and in at least 40% of the cells present. And what you see is that the patients treated with zolbetuximab plus chemotherapy did better than the patients with just chemotherapy alone for progression-free survival and for overall survival. And the backbone chemotherapy in this predecessor study was epirubicin, oxaliplatin, and capecitabine. And so this triplet regimen, which is a magic backbone regimen, is now outdated, but this was the regimen that was sort of in vogue at the time. An important subgroup analysis of this study was looking at patients that were either 40 to less than 70% of the cells staining at 2+ or higher intensity, or those that had the more than 70% of cell staining at least 2+ intensity. And you can see for both progression-free survival and overall survival that all of the benefit is derived from the patients who had a more than 70% of the cells staining with this intensity. Those that were sort of some of the cells, about half of the cell staining, didn't seem to do any better with the zolbetuximab compared to chemotherapy alone. And so this set the stage then for the phase 3 studies, the pivotal phase 3 studies, to confirm this finding and to hopefully be true, and then lead to a new standard of care. And so that led us to SPOTLIGHT study. SPOTLIGHT was a study that changed the chemo backbone. It changed the backbone to FOLFOX chemotherapy, because that, of course, is our preferred regimen, especially in the last 10 years. And it was a placebo-controlled study of zolbetuximab or placebo. So patients and physicians didn't know which of these two were being administered. And on the left, you see progression-free survival, and on the right, you see overall survival. And you can see that the overall survival was improved, and the absolute benefit was an increase in 2.7 months median. And their hazard ratio, remember, is an important number because it really takes into account the performance of the control arm compared to the performance of the experimental arm. And so you note here that the control arm actually does a little bit better than what would be expected compared to most, if not all, phase 3 studies, which usually hovers around 12 to 13 months as a median overall survival, whereas this one was 15.5 months. And so the experimental arm with zolbetuximab did even better than that at just over 18 months. And so really, again, it's the comparison between the two. And so the hazard ratio really is the number that is useful when comparing against other studies, or so-called cross-trial comparisons. It's important to know that there was a second large phase 3 study called GLOW that was being run simultaneously. GLOW was a study that had some differences. First off, the chemo backbone was capecitabine and oxaliplatin, CapeOx, so the oral version of 5-FU, as opposed to the IV version, FOLFOX and SPOTLIGHT. In addition to that, the GLOW study was mostly enrolled in Asia, whereas the SPOTLIGHT study was a global study. It included some Asian patients, but it was a global representative study. In addition, of course, FOLFOX is given once every 2 weeks, whereas CapeOx is given once every 3 weeks. And Zolbetuximab is given once every 3 weeks. And so Zolbetuximab with CapeOx is really being given once every 3 weeks, and the oral pills are given 2 weeks on and 1 week off. With FOLFOX, the FOLFOX is given once every 2 weeks, and the 5-FU pump for 2 days. And Zolbetuximab is given once every 3 weeks. So it's sort of awkward and a nuisance in order to administer this, because you're coming almost every week. There's 1 week off, but then you're coming weekly sometimes. So it is a difference between the FOLFOX and CapeOx backbone and how the drug is administered. It may be in the future that Zolbetuximab will be able to be given once every 2 weeks, just to make things more streamlined. And so you come every other week all the time, and it's not changing, and it makes it a little bit easier. But technically, the regimen that will be approved will be FOLFOX every 2 weeks, Zolbetuximab every 3 weeks. So these two studies were both positive, and you can see the added absolute benefit in median overall survival were very similar. The hazard ratios were very similar, but case in point here, in terms of the actual medians, you can see here the median overall survival in the control arm in the SPOTLIGHT study was better than the median overall survival in the control arm of the GLOW study. And the experimental arms were also both better, but different from each other. And so this is where the hazard ratios become really important, and you can see they're nearly identical. So interestingly, despite the improvement in progression-free survival and overall survival in both of the studies, the response rate in the SPOTLIGHT study shown here were not different. And so it's interesting also to see that the placebo arm is such a high response rate. That's higher than expected with just FOLFOX alone. Usually most studies hover in the 40 to 50% range of patients that will have an objective response. So random variation, subjectivity with the CAT scan, et cetera. And so you get some variation from study to study. And, we know how FOLFOX normally performs, and this is higher than usual. So regardless, there's not a dramatic difference in response rate in the Zolbetuximab arm, but as noted, what I think is most important is that it kept patients' tumors controlled for longer than control, and also survival was better. In terms of tolerability of Zolbetuximab, you can see here on this slide comparing Zolbetuximab to the placebo arm. And remember, in clinical trials, all of the side effects are graded on a scale of 1 to 5, 1 being the least severe, and the higher the number, the more severe. And you can see that for grade 3 or higher toxicity, there was an increase in about almost 10% in the Zolbetuximab arm. And the treatment-related adverse events leading to discontinuation of therapy was higher in the Zolbetuximab arm compared to the placebo. So there were patients that were stopping therapy because of side effects higher in the Zolbetuximab arm. What were the side effects? That's shown here. And so you can see the list of all the different side effects. And on the left side in red are the Zolbetuximab, and on the right in gray are the placebo group. And the lighter colors are any grade, and the darker colors are the higher grades, grade 3 or higher. And you can see what's highlighted here, the ones that are the most different between the arms, because the rest are all pretty similar. Suggesting that the Zolbetuximab doesn't cause an increase in these compared to placebo, but where it does cause an increase compared to placebo are with nausea, vomiting, and decreased appetite. And so this was definitely seen in the study where patients were having a lot of nausea, vomiting, and also decreased appetite. But it's important to note that on this slide, you can see here for nausea and vomiting, and on the x-axis is the interval onset in the days. So each one of these represents a cycle, the cycle being 21 days. And you can see that it was highest in the incidence of nausea and vomiting was highest in that first one cycle. And then after that, it sort of dissipates. And so there's a tolerance that's generated over time. Plus, potentially some modifications of the therapy. For example, I noted in the chemotherapy videos that FOLFOX is given with a bolus, and that causes a lot of nausea and vomiting in and of itself. And for example, in my practice, I don't use that in any patient, but certainly if it's being used, that will be something that is dropped right away if you're getting, a lot of nausea and vomiting. And so alterations in the therapy over the next cycles often decrease the incidence of this, also with increasing the supportive measures in terms of anti-nausea medications at the time of treatment and through the cycle can also improve that. So for all these reasons, it's front loaded and then it sort of gets better over time. So in addition to that, the nausea and vomiting, decreased appetite, there is a known sort of infusion reaction that occurs with the regimen, and that is something that needs to be aware of, that the drug needs to be started at a slow rate when it's being infused in that first cycle, just to sort of ease into it. And as you're showing some tolerability of the drug, we can increase the rate in which it's dripping in during that first infusion. And then with subsequent infusions, usually you can go a little bit faster. But some patients had a reaction to this called an infusion reaction, where, again, a quick onset of nausea, vomiting, even stomach pain has been described with the administration of the therapy. And so these are all things to be aware of, that it's on the day of the treatment and then sort of dissipates quickly when you go home, that infusion reaction. So the side effects of nausea and vomiting that are even grade 1 and 2, as you saw on the previous slide, are higher in incidence compared to the placebo control, are important and need to be recognized. But again, to show that it does dissipate over time, and that there are measures that one can take to try and improve on that. And in the context of improving survival, this is a victory in my view. And so in the context of that, this therapy will likely be approved and will be a good option for patients with Claudin high tumors. So the next obvious question, though, is what about adding anti-claudin antibody, zolbetuximab, with immuno-oncology anti-PD-1 therapies like nivolumab or pembrolizumab or other anti-PD-1, PDL1 therapies? And so again, here's the image of the anti-claudin antibody, zolbetuximab, binding to cancer cells and recruiting NK cells through ADCC, the innate immunity arm. And I encourage you to go back to our immune system video where we talked about innate versus acquired immunity, because with the recruitment of NK cells into the vicinity and tumor destruction, the release of antigens can then start to sensitize and recruit T cells. NK cells in the vicinity are also secreting a lot of cytokines and recruiting other immune cells like T cells. And so when T cells are in the area, cancer cells will start to upregulate PDL1, remember? And so this is where anti-PD-1 antibodies will maybe be synergistic with antibodies that are driving ADCC with NK cells. And we showed that in the previous lecture with HER2 positive tumors, where we were looking at trastuzumab and pembrolizumab, or margetuximab and retifanlimab. And so now the concept of zolbetuximab in one of these PD-1 inhibitors, could that do even better than either one alone? And so in this lecture, we talked about FOLFOX with zolbetuximab, and the eligibility criteria was for Claudin positive tumors. But we have to recognize that some tumors that are Claudin positive may also be PD-L1 positive. And for that matter, some Claudin tumors may also be HER2 positive. So in the latter example, remember the SPOTLIGHT and GLOW studies did not allow HER2 positive tumors. So that has to be studied separately. And at the moment, there are not any large-scale studies looking at Claudin inhibitors in HER2 positive space yet. But with respect to the question of a Claudin positive tumor and a PD-L1 positive tumor, this is very relevant, and we're going to need to talk about that. So what are we going to do if a tumor is both PD-L1 positive and Claudin 18.2 positive. We talked about in the previous lecture where anti-PD-1 therapies with nivolumab in gastroesophageal adenocarcinoma and pembrolizumab in gastroesophageal adenocarcinoma on the most recent study, Keynote 859, were both positive studies, and their hazard ratios were pretty much the same. And so these are options in all comers. Spotlight study, as you can see, what we've been talking about with Claudin positive tumors, has a hazard ratio that's similar to that. The median overall survival absolute benefit's a little bit higher, but the hazard ratio is also slightly better. But we also have to remember that PDL1 negative tumors really derive no benefit, and PDL1 positive tumors is where it was at with a hazard ratio of 0.66 and an absolute difference of 3.5 months with nivolumab. The same things were seen with the most recently reported Keynote 859 study a few months ago with pembrolizumab. Remember, this was the second study done in gastric cancer with pembrolizumab. The first one was Keynote 062, which was trending but was overall negative. And so a much larger study was conducted and then was positive and pretty much identical outcome to Checkmate 649. Not surprising, because nivolumab and pembrolizumab to me is like interchangeable. It's like Coke and Pepsi, and they're very, very similar in action and activity, and usually show the same results when they do the same study. So the difference here, though, is that Claudin and Zolbetuximab was not studied in the Claudin negative patients. It was, they remember, they weren't eligible for the study. You had to have overexpression of Claudin to be eligible, and the hazard ratio here again is 0.75. So there will be a number of possibilities with a newly diagnosed patient and their tumor. These are all the different situations. You could have negative for PDL1 and negative for Claudin, negative for one, positive for the other, and positive for one, negative for the other, and both positive. And so just juxtaposing the hazard ratios in each of these situations, where PDL1 being negative, the hazard ratio being 0.9, a Claudin being negative, again, not tested, et cetera. And you can see sort of the matrix that you can do, that ultimately we're going to need to prioritize our options depending on what the given profile is in the given patient. And so the other thing we have to remember is that the incidence of a PDL1 above 10 is around 15 to 25%. In some series, it's even as high as 50%. I showed you in some of the trials, but I think that those are higher than what we see in the real world, and partly due to pre-selection of patients and an overinflation of the real incidence in the trials. And then again, the Claudin incidence is about 25 to 35% positive. And that leaves us with a large proportion that are going to be double negative. And these numbers don't add up to 100% over here. And that's because there is overlap. Some tumors are positive for PDL1 and positive for 18.2. And so these incidences are split in that group. And in addition to the complexity that's now being introduced here, as you can see with PDL1 and Claudin, if we start to add other biomarkers that are established, and we'll talk about in the next lecture, like NET and EGFR, or emerging ones where there are phase 3 studies ongoing with FGFR2, if these get factored into here, you can see the fragmentation that occurs and the considerations that are going to need to occur to find the best therapy option in any given patient. And if you go back to the principles of molecular profiling, the third video in that series where we talked about molecular heterogeneity and biomarker assay performance, we introduced the Pangea study, which is a study that recognizes the extreme heterogeneity of different genetic and protein biomarkers from one patient to the next, and how we should start thinking about trying to prioritize our therapies and give each patient their best option. So they may have more than one option, but what is their best option? And so at the moment, these are the NCCN guidelines. And remember, these are guidelines that are generated by experts in the field in the country. And they aren't necessarily the same as FDA approvals, but these are usually what's used by insurance companies. And so on the right side is gastric, and on the left side is esophageal and GE junction. And they're essentially the same, but again, they're not identical. And that's because some studies were done in only one versus the other. And so, specifically looking at HER2 negative disease, as shown here, on the right side, we have currently chemotherapy either alone or with nivolumab, category 1 with above 5 PDL1 and category 2B for less than 5. And in the esophagus and GE junction, we have the same. It's all listed here for nivolumab, so category 1 above 5, category 2B for less than 5. But here we also have pembrolizumab listed for above 10 or less than 10 with either oxaliplatin or cisplatin and their categories respectively. And so remember, the reason why pembrolizumab is listed on the esophagus and GE junction and not in the gastric is because the Keynote 590 study with pembrolizumab was positive, which included these patients, but the Keynote 62 study was negative. Now, because the Keynote 859 study was positive, the follow-up larger study, we expect pembrolizumab to be listed here as well, just like it is on the esophagus and GE junction. And now, with the SPOTLIGHT GLOW studies, we expect to see zolbetuximab added to both of these. And it will probably say chemotherapy with fluoropyrimidine, fluorouracil, or capecitabine, with oxaliplatin and cisplatin, with zolbetuximab for Claudin positive tumors, which was defined as IHC intensity 2 plus or higher, and extensity of cells, at least 70% of the cells are higher. So what are we going to do in the situations where both PDL1 and Claudin are positive? Or what are we going to do in each of the situations, each of the scenarios that could occur? And so in the setting of HER2 negative tumors, let's start with the easiest first. If PDL1 is negative, less than 10, and Claudin is positive by the criteria, then I would recommend logically FOLFOX with zolbetuximab, not an anti-PD-1 therapy. And that's because the direct comparison of the hazard ratios is in favor of Claudin. Let's look at the other extreme with PDL1 positive, CPS above 10, and Claudin negative. In this case, the logical thing would be to use FOLFOX with anti-PD-1 therapy, whether it's nivolumab or pembrolizumab, but not zolbetuximab. Remember, these patients that were Claudin negative weren't even eligible for the SPOTLIGHT and GLOW studies. What about if they're both positive, though? This is where it gets interesting. If PDL1 is high and Claudin is positive, then you're looking at the hazard ratios. The hazard ratios in favor, the absolute benefit is actually in favor of the anti-PD-1 therapy. In addition to that, probably better tolerated, less nausea, vomiting, etc., compared to zolbetuximab, although it comes with, remember, an increase in 10 to 15% of grade 3 toxicities and immune-related side effects. That said, when you're looking at them head-to-head and they're both positive, in my opinion, I would recommend anti-PD-1 therapy in this situation. In this setting where they're both negative and very low PDL1, then the recommendation, in my opinion, should be standard chemotherapy with FOLFOX. You could consider a triplet chemotherapy like FLOT or FOLFIRINOX in select cases. And remember, the hazard ratio was no different in the PDL1 negative tumors, and Claudin negative tumors were not even eligible for SPOTLIGHT or GLOW. So this would not be an option for zolbetuximab anyway. And what if, though, the PDL1 score is in between? And, we see that that nivolumab is recommended to be considered for CPS above 5. So what if the CPS is above 5? I've been going through the last lecture. You heard my opinion about what is an optimal cutoff for PDL1, whether it's 5 or 10. And all of the evidence really points to being above 10, but we haven't explicitly seen the outcomes of patients between 5 and 9, which tells me it's probably not dramatically improved, but we don't know exactly what it is. And so, especially when Claudin is negative and you don't have an alternate option, one could consider PD-1 therapy, but one could also consider a triplet chemo if one to be a little bit more aggressive. And certainly clinical trials are always encouraged, but it is a sort of this gray zone that one could consider a PD-1 therapy in that situation. So in this video, we talked about first-line setting for Claudin-positive tumors. We showed the evidence of the SPOTLIGHT and GLOW studies that came on the heels of the previous phase 2 study, FAST study, and we expect this regimen to be approved by the FDA in coming months. This is June of 2023 at the time of the recording of this video. And so we will be expecting that therapy. And I talked about the different considerations in the setting of other biomarkers and what one might could do. And another important question that patients are going to ask are patients that have already been diagnosed for some time and have already been on first line and maybe later lines of therapy. Are they going to be eligible now in retrospect for zolbetuximab once it becomes approved? And that's a really good and important question. Technically, you wouldn't be eligible because it will be approved in the first line setting. That said, most insurance companies, in my experience, will sort of grandfather you in because the drug wasn't available at the time that you were at first line. And certainly it should be tried and discussion with insurance company to allow for that. Over time, all patients will be considered for this at the newly diagnosed setting. So we've talked now about the three important biomarkers in the first line setting. In addition, MSI high tumors, which tend to fit in the PDL1 positive tumors. And so now we're going to be talking about negative for all of these biomarkers and what is the optimal therapy in that situation in the next video. In terms of ongoing studies in this first line setting of Claudin positive tumors, we talked about how the obvious next steps would be, what about combining zolbetuximab and a PD-1 therapy, especially if they're double positive? And you, instead of having to choose one or the other, it's likely, or at least a good hypothesis would be that doing both will be best. And so early phase studies of these are being conducted in phase 1 and phase 2. And we're a little ways off from a phase 3 study, but should be encouraged to consider that if there's a study like that near you. So it'd be good to keep your eyes open for studies like that. And another possibility might be if patients do have both biomarkers present, is a possibility of using a chemo-free approach with just the targeted therapies, like we talked about with margetuximab and retifanlimab in the HER2 positive lecture. So in this video, we talked about Claudin positive tumors, and we talked about zolbetuximab, the targeted therapy towards Claudin 18.2. We talked about the mechanism of action of zolbetuximab, and we went over the recent data of 2 phase 3 studies, the SPOTLIGHT study using zolbetuximab with FOLFOX and the GLOW study using zolbetuximab with CapeOx, and both studies being positive, and that we do expect FDA approval of this in the near future, hopefully, so that this will become eligible for our patients. Stay tuned for the next video, looking in the first line setting at therapy for tumors that are triple negative, HER2 negative, PDL1 negative, and Claudin negative, and looking at emerging biomarkers in that setting and optimal therapies for those patients. Thank you.